Most important cause is a ruptured secular aneurysm. Trauma, EVM, vasculitis, dissections, amyloid, bleeding diastasis, and certain drugs like cocaine. My talk is basically going to stress on secular aneurysm. What are the risk factors of a subarachnoid hemorrhage? Any subarachnoid hemorrhage? Smoking, hypertension, heavy use of alcohol. Please remember the family history, first degree 3 to 4 increased risk, pills, oral contraceptives, antithrombotic agent, and a severe physical exertion can precipitate. So please do remember that if a patient comes to your emergency, young man, that he was in the gym, he suddenly developed a headache, please think of subarachnoid hemorrhage. If you have a patient who tells you, I was flying from Mongolia to India, and as flight was coming down, I had a very severe headache, a bursting headache which I had never had in my life before. It is subarachnoid hemorrhage. What is subarachnoid hemorrhage? As I just said, you have to bear with me. I may repeat certain things because I would like to stress on certain points which you should be absolutely clear about. Usually, it is a rupture of an aneurysm which releases blood under arterial pressure into the CSF. What is after an aneurysm? An aneurysm is a balloon dilatation of the artery. And this balloon dilatation of the artery, it bursts because of factors we just talked about. So, it produces blood which goes quickly, increases the intracranial pressure. Bleed lasts for a few seconds, but don't remember, if you have one bleed, for heaven's sake, don't wait for the second bleed. That is why, if a patient walks into your specialty, into your hospital with a subarachnoid hemorrhage, there is no day, there is no night, there is no morning. He needs to be treated. Because the mortality of a rebleed is 70%. All happens quickly, leading to symptomatology. It gives you no time. You make a round, you have a subarachnoid hemorrhage with you, you go to the third bed. Sir, the patient of the subarachnoid hemorrhage has deteriorated. He is rebleed. He was grade 1, grade 2, grade 4, grade 5. Sorry, the prognosis becomes very bad. So as I said, there is no question of a delay in the treatment of subarachnoid hemorrhage. 97% have headache, sudden onset, unilateral, worst headache of his life, 30% in the night, lateralized to the left side. I'll give you a small example. Recently, I had a patient who developed a lateralized headache for the first time in their life during the act of sexual intercourse. He did not give much importance to that. Till the time, the headache persisted the next day. He came to our services. We very well knew, and we could imagine that this was a subarachnoid hemorrhage. So that's what I said. Any stress, strain, increasing the intracranial pressure, increasing the blood pressure, causes an asymptomatic aneurysm to bleed. 30% occur in the night. There is loss of consciousness. They can present with seizures, neck stiffness, commonly not bad. Low back pain. Please remember that low back pain is a very important feature. 30 to 50% may have a minor bleed 6 to 20 days prior to a large bleed. What are the complications? Why do you want to treat subarachnoid hemorrhage? Oh, sit over it. Chances of rebleed. An entity called vasospasm, which we'll come to a little later. Hydrocephalus, which means there's obstruction to the flow of CSF, as a result of which the ventricles dilate. And this is called hydrocephalus. Raised intracranial pressure. Seizures, very common abnormality, is hyponatremia. If you watch, at least in my own experience, as a neurologist when I manage a subarachnoid hemorrhage, I would say 60 to 70% of patients of subarachnoid hemorrhage have hyponatremia. And sometimes they are deteriorating. They may not be deteriorating because of a rebleed, because of seizures, because of hydrocephalus, or because of raised pressure. They may be deteriorating because of the hyponatremia. What is the dreaded complication? Rebleeding. Highest risk within the first 24 hours. That's why I said, don't slip off. Don't sleep off. Time is important. If he comes to you at 2 o'clock in the morning, he needs to have an angio. He needs to have a clipping or a filing. Most occur within 3 days. Worst clinical picture is presentation, highest risk to bleeding. That means if his grading is lower, more chance of rebleed. Acute decompensation and prevent aneurysm treatment. Now, first of all, complications of vasospasm, a dreaded complication. Why does vasospasm occur? It is an ischemia or infarction in 20 to 30% of subarachnoid hemorrhages. It is a major cause of death and disability after aneurysm rupture. Maximum day 3 to day 8. Why does it occur? There are spasmodic substances from the lysis of blood clots. And one of the substances which has been implicated is oxhemoglobin, which causes endothelial damage and no smooth muscle contraction, which causes what is called decreased amount of nitrous oxide production. As you all know, that we are all getting interested in nitrous oxide. The role of nitrous oxide and cyclic GMP in endothelial dysfunction. So this nitrous oxide has to be taken very seriously. Even the same thing occurs in the endothelial dysfunction in a stroke patient. The risks are younger age, size of bleed, and the clinical presentation. Seizures, predictors of a poor outcome, at times very difficult to treat. They get into status epilepticus, and seizures is a bad clinical sign, which would mean that the patient has developed evidence of vasospasm and infarction. Complications of hyponatremia, hypothalamic injury, increased ADH, and cerebral weight wasting causes hyponatremia, which needs to be corrected. Please don't forget one thing, that there are a lot of cardiac changes. So if you are monitoring a patient of subarachnoid hemorrhage, you're looking at his pupils, you're looking at his plantar, you're looking at his blood pressure. Don't forget the heart. The EKG shows ST depression, QT prolongation, deep T2A inversions, U waves, and they get subendothelial injury with acute myocardial infarction in 20%, which is very, very high. They get afibrillation. It is all because of the centrally mediated catecholamine release within the myocardium from hyperperfusion of the posterior hypothalamus. So that's what I tell my students, tell my postgraduate. Please don't be under the impression that subarachnoid hemorrhage is some blood in the subarachnoid space. It causes hypoperfusion even to the posterior hypothalamus, which is the cause of the EKG changes. The diagnosis, very easy. No, not very easy. Why I say not very easy? Because your mind must think. But if you made a diagnosis, then that's very good. Take a good history. Please carry your ophthalmoscope with you. Just do a CD head. The role of LP is limited, which I'll come to a little later. Not much role of an MRI scan. The CT is diagnostic. So please don't run about with MRI scans, even if you have 10 in your center. 95% sensitivity in the first 24 hours. So if you have a subarachnoid hemorrhage, which is scanned in the first 24 hours, you will pick up blood in the subarachnoid space in the 95%. Please be surprised if you have a neck stiffness or subhyaloid hemorrhage and you don't find blood. Please go back to your CD center. Request them to take thin cuts through the base of the skull. Don't give any contrast. When you want to see blood, you don't want to give a contrast. You want a plain CT. If suspect subarachnoid hemorrhage and CT, then you could do a non-diagnostic lumbar puncture on the 4th or 5th day. Please see this picture. Very clearly, you can see blood in the basal cisterns. Please this picture again. You can see the white blood all in the subarachnoid space. Diagnosis. If CT head is normal, LP, look at the elevated opening pressure and elevated RBC that does not decrease from Q1 to 4, xanthochromia, and spectrophotometry to look at xanthochromia. Diagnosis no better than non-contrast CT. I again stress, there are certain conditions a non-contrast CT is the answer. There is no point running for MRI. The other situation, if in your center you do thrombolytic therapy, if a patient comes to you the therapeutic window of 3 to 4.5 hours or 3 hours, you do a CT, it is normal, you go and thrombolize. You don't do MRI in everybody. Diagnosis for the underlying cause. Searching for aneurysm that could be surgically corrected. Yes. Diagnosis, cerebral angiography, CT angiography preferable over MRI angiography. Say, for example, in 10-15% of patients, you don't find an aneurysm. We see that at time because of the blood. The aneurysm has got thrombosed. So you may not see it. So you should repeat an angiogram after 4 or 14 days if the first one is negative. Treatment depends on the severity, presentation, age, amount of blood seen on the CT, and of course, most importantly, on what grade is your patient in. I won't bore you with the several different scales used for severity that you could look into any textbook, the Glasgow Coma scale and the Hunt and the Huss scale. Treat acutely and deal with lesser complication. Manage these patients in ILU. See that they are not constipated. Discontinue anticoagulants and antiplatelets. If they were an anticoagulation, reverse anticoagulation. DVT prophylaxis could be given in a situation which you decide. Treatment of BP, very important. If they're increasing ICP, their BP needs to be kept elevated. However, elevated BP increases the risk of rebleeding. So you got to strike a balance. The pressures are high. What decides the intracranial pressure is the arterial blood pressure. Okay? If the arterial pressure rises, the intracranial blood pressure rises. So what you like to do is keep them in tandem to each other. You have to balance each other so that you don't increase the intracranial pressure, you don't cause infarction, and you don't cause rebleeding. Buccal-plated ventriculostomy to monitor ICP depending on the facility. If the patient is alert, then CPP likely educate and maybe can safely lower the blood pressure. Vasospasm, we used to have a therapy called triple H therapy. Even still, if you look at the standard textbooks, hemodilution, induced hypertension, hypervolemia. Hemodilution, reduce the blood pressure, increase the volume. But now this is not being followed anymore. What we follow in our center is the nimodipine infusion, which is the most standard infusion to prolong or not to have vasospasm. Seizures, you could use any antiepileptics that you are fond of, makes no difference to me. So what is the treatment? Treatment is clipping versus coiling. Clipping means you take the patient to the theater, look at the neck of the aneurysm, clip it. If you clip the aneurysm, it goes away from the main circulation. You got your job. You have cured the patient. See, understand one thing, that here you are giving a cure. The other treatment is endovascular, where you can coil the aneurysm, coil it, the patient, the aneurysm will be shut off from the circulation. So the circulation becomes independent of the aneurysm. Screen for aneurysm recurrence, especially screen family members. So friends, I think I've fairly well taken you through the management treatment in subarachnoid hemorrhage. Thank you. I end by saying what the World Stroke Organization say, 1 in 4 of us will have a stroke. Don't be the one. Don't be the one. Please join the World Stroke Campaign against stroke. Thank you. And if you have any questions, I'll be too glad to answer them.